Hello, mate, to Thrive Nation. It's going to be an exciting episode about the future of health, technology, and a company called Medici. I've got Dr. Coburn Allen on the show. He's a pediatric emergency specialist. He's a pediatric infectious disease specialist, and he's the chief medical officer of Medici, who are changing the world with regards to healthcare. So welcome to the show.
Oh, great to be here. Thank you.
Brilliant. Let's just start with the current status of health. And I talk about the four horsemen being cardiovascular disease, cancer, neurodegenerative conditions as metabolic conditions, mainly diabetes and prediabetes. What is happening with the current status in the US and worldwide?
Well, certainly in the US, things are not going well. You know, what we are seeing compared to our democratic peers around the world is we're actually the least healthy population right now. Probably 2x of most chronic diseases that are related to lifestyle. So certainly we have a massive problem with obesity, but right now in the States, 60% of Americans that are adults have at least one chronic disease related to lifestyle. And at 40 have two. And so the average person almost fits into a complex disease management category in the United States right now. And what's really sad is that most Americans that have these complex diseases don't recognize the significance of them and actually don't believe there's anything they could do about it. So the average American literally does not think there's anything they could be doing about their diabetes or their obesity or anything else. It's just a long decay in people thinking about their health proactively.
Oh, that's pretty scary. 60% of what, 350 million in that case have one chronic condition, 40% have two chronic conditions. Well, where do you start? I know you're the chief medical officer at Medici. How do you change this narrative and how do you change these statistics?
Yeah, you know, it's part of this now is getting at just motivational interviewing and how you get a patient to start to acknowledge that they need to change. So it's really gotten to the point where everything is integrated with behavioral health, a way of thinking. And so we actually do have behavioral health integrated into all of our chronic disease programs because it starts with people's thinking about their health, but it also starts with that primary care relationship. So we're a big believer that primary care has been massively devalued in America. And that probably is a little bit of the conspiracy theory we have is that, of course, because we get paid for sick care, why would we value primary care, which is all preventative in focus? So we do now have a massive problem and we have to start doing multifactorial approach to how we get people to re-engage in their health and to get medicine, doctors, and the people that support them to re-engage in thinking about prevention and healthy living and these things.
But how are you doing that practically? I mean, it sounds all sort of nice theoretically, and obviously we want to change people's thinking regarding what they can do for chronic disease and then impact the healthcare providers. But what are you doing from a program and practicality perspective?
Yeah, so it's very multifactorial. So everybody's on the same page that we are always going to talk about unhealthy patterns. And so right now in the States, it's almost taboo to say things about people's health, to even acknowledge that the way, maybe the overdrinking, the smoking, the diet, the lack of exercise, it's really like there's a whole fat shaming sort of discussion happening right now, which is incredibly unhealthy. We do need to be sensitive to people, but we also need to not stop thinking about the obvious things that are causing most of our chronic disease. So our whole team is trained in lifestyle medicine. We incentivize our doctors, we incentivize our nurses. Even my behavioral health team is getting credentialed in lifestyle medicine and prescribing exercise as much as they prescribe perhaps things for depression and anxiety. So we're all on the same page there. And then we do a lot of training of our care teams to start to really engage patients in those discussions. And it starts with a lot of surveys. We do extensive amounts of surveying about lifestyle. When we onboard a patient, it's not secretive. It's pretty understandable that we are going to ask you questions that perhaps you've not been asked very often, including screening for behavioral health issues, as well as what is your current diet? What is your current exercise? What is your addiction profile? All those things. How are you sleeping? What's your social connectedness? And then we have triggers within that. Before we've even seen you once, we know the first visit we have with a patient, what things we are going to begin discussions with. And then that's where the whole training and motivational interviewing comes in, where our doctors and our nurses and our concierges and our health coaches are all trained in finding that little kernel of wisdom within the patient that gets them to start to think, you know what, I probably can start doing some changes. And what we know is that small changes with a peer group behind them and supporting them, and we provide that peer group, leads to little bigger changes, which leads to sticky habits, which leads to trajectory changes in your life. So that's our pattern. And then we surround people with as I mentioned, a peer team. So what that looks like at Medici is we have lifestyle medicine doctors, we have exercise physiologists that work on actually prescription of exercise and lots of iterations of those. We have dieticians. We have tools that we use between visits. So there's this constant care model where people can do some self-directed care. Once we get them to engage a little bit, sometimes they don't like the stigma of having to talk to somebody about it. They'd rather talk to an automated way of doing that. So we have lots of tools that help them do their own self-directed care, but we do check-ins with health coaches and care teams to make sure that there's progress. And really what we find is with 3 to 6 month programs for lifestyle interventions, for behavioral health interventions, is that the expectation is cure. We're looking for cure of disease and not management of disease. And we talk a lot about and actually incentivize our care teams to care about disease reversal and not disease management. We're purposeful in those words. And we know it's doable especially when you give the doctors and the care team the time to do it, as well as incentivize them. So we actually have pay tied to reversing of disease, as opposed to almost nobody in what we call the fee-for-service side in healthcare is at all incentivized in that manner. In fact, it's like, if I don't have sick people, I don't get paid. In my system, I want you to keep people well, and I'll pay you to do that.
Oh, sounds amazing. Just take us through the journey now of someone who would go through the traditional care model and more sick care. And so, they get disease management and not reversal, versus the Medici way, or what I call, medicine 3.0, which is preventative and proactive. So tell us about those two journeys and how you've transformed someone's life via this new way of healthcare.
Yeah, I mean, the traditional journey, what we call fee-for-service here, is really a sick care system, as I mentioned. What that looks like is the average patient doesn't really even have primary care. They don't have a quarterback. They don't have anyone that's talking prevention. So less than 30% of Americans really have true primary care and someone that's thinking preventative. So the average person is actually trying to navigate their own healthcare. And what they're doing, in essence, is they're waiting for illness and then they're going to specialists. So in America, we spend about $5 on outpatient specialist care for every dollar on primary care. That's a pretty staggering number. In every country that's figured out health better than us, which is a lot of folks, frankly, they know that primary care has to be just foundational. And we know that in the States as well. At least our thinking folks about how healthcare should be done are talking about that. But we just don't promote primary care. So what happens is people are going to 4, 5, 6 specialists, none of which speak to each other, all of which are getting paid. The sicker you are, the better they get paid. And so we have this system that really rewards illness and pays well for illness, doesn't pay anything often for prevention of illness. And so what you get then in return is a lot of people that are seeing specialists that get into hospitals. And, so we're spending 5 times more on primary care and specialty care, but we're spending, at least 25 to 30% of our overall budget is on hospital care in the United States. So we just have crazy priorities. So in our system, which is a value-based model, we very much value primary care. And so we believe everything should go through the lens and that quarterback and that relational sort of thing of primary care with the patient, that patient-centered primary care, we call it in the States. And when you do that, you have a primary care doctor that's given the time and the resources to do prevention and to do complexity. And so it's both that matter. And then we believe strongly at Medici, and we're a faith-based group. We believe that philosophically that we were called into medicine. Many of us feel that way strongly. And part of that calling is that there's compassion behind that. And so we're big believers in compassion. And we encourage all of our doctors to read a book called Compassionomics that really reinforces that compassion is probably the most evidence-based thing you'll do in taking care of a patient. It leads to engagement. It leads to better patterns. It leads to decreased testing. It leads to decreased referrals. And it frankly leads to the doctor enjoying their job more as well. And so our providers that are compassionate in the States, we know actually have way lower burnout as well. So our 3-pronged approach is prevention, real prevention, meaning we're up to date on things that are proven. We do complexity, meaning we do a lot of internal consults. We have our own internal specialists that my doctors go to on your behalf. So primary care doctor to specialist, to really avoid you having to wait 6 to 8 weeks to go see a cardiologist that then tries to take over care. So we really do a lot to do that. And then we try and do it through the lens of compassion, and that relationship matters. So we actually measure compassion after all visits with our providers. And our providers get feedback on that, and they start to learn, oh, I think I'm compassionate, because there's actually a real disconnect between providers believing they're compassionate and patients saying you're compassionate. So we want that feedback for our providers, and it really gives us an opportunity to rapidly improve. And when you measure on it, frankly, you do it. So you can even fake compassion. It's been shown. You can give a anesthesiologist a script that's compassionate versus one just a regular script about your pre-dosing for surgery. And then after surgery, the compassionate scripted patient actually has fewer needs for morphine. That's crazy, but we are wired for compassion. Patients are wired for compassion, and doctors are wired to be compassionate, but if they're not given the time and the resources to do it, they won't do it, because they're frankly squeezed too much in the health system.
So when you say primary care physician, are you talking about a medical doctor, or who are you talking about, the connection point, the quarterback that you're speaking about?
In the States, that serves usually as an internist, family medicine doctor, pediatrician, but there are also mid-levels, nurse practitioners, PAs. And then truthfully, we believe the shift will get towards a health coach, right? So a health coach being that the person that really understands nutrition and exercise and putting all these pieces together. And so we have health coaches as well. So we're not really, I wouldn't say that we think of ourselves as a doctor-only primary care system. We think of it as a primary care team, and that team includes all those components with that lifestyle focus.
Brilliant. Now, when you say your doctors or your you got a corporate, and then they go to your primary care team, those PAs and MDs and health coaches and nurse practitioners and all that, they come to your team and then they get directed to specialists within your network, or can the client go outside of that?
Yeah, so our average team will be curated primary care doctors, nurses, health coaches, concierges for a large company. That's our typical client right now. So a client with more than a couple thousand lives is a good opportunity for us to put together a primary care team. And that always includes at least one full primary care provider, a nurse, and all those support pieces around that. And why that's important is that relationship is critical to that compassion piece we talked about. And it's also critical to that longitudinal kind of benefit of care, is like, I know you now, I can know we can avoid you going to the ER for this because we've dealt with this in the past, and we can keep you out of expensive care. So yeah, absolutely. That's the core. And then our surrounding pieces, all the specialists, those will maybe take care of multiple clients. And so we'll have a cardiologist, for instance, that within minutes is talking to you or my PCP about, do I really need an EKG for that patient, or can I simply just go ahead and start that medication that may affect cardiac rhythm? So those sort of quick ability to get to a specialist are really a big part of our managing of complexity, and frankly, offloading frustration. So in primary care in America, most fee-for-service primary care doctors are just shunting people all over the place to specialists. That's really what they're spending most of their day doing. In our system is we actually incentivize internal specialists, where you as the PCP are going to the specialist on the patient's behalf. You can't do that without time. So most of our visits are 30 minutes to an hour. So my primary care doctors and team have the time to do all the prevention and the coordination. There's an interesting study in America. If you just did grade A and B preventative measures with the average fee-for-service panel of patients, and the average fee-for-service panel is 2,000 to 3,000 patients that a primary care doctor is trying to take care of. If you just did the recommended pieces of prevention, it would only take you 26 hours a day. So, so obviously there's got to be better systems to do the preventative things. And that's where we use AI and pre-screening tools and health coaches and all these other pieces to get the preventative stuff done and make sure it gets done. So our concierge is making sure you get to that mammogram, making sure you get to that colonoscopy if that's what you need, and so forth. So we're really good about offloading of some of those frustrating things in primary care to our other care team members, but we do make it part of the primary care doctor's responsibility to make sure that patient is up to date on those really proven return on investment sort of things like preventative care.
And do you reward them if they carry on with those tests or carry on with the program, or make sure they, finish the nutritional plan or the exercise plan? Do they get rewarded in a way to obviously motivate people in this sort of space is a difficult one?
Yeah, so we reward our care teams for being advocates and getting those people through those, and we reward our patients. So we have incentive programs as well. And we help make it's funny, a lot of Americans actually have some of this built, the employed Americans will have something built into their benefits called a wellness program. And it includes real money for them to get stuff done. And we're finding that for companies that we come into to help, that less than 5% of people sometimes are up to date on things where they have up to $1,000 or $1,500 in benefit to just get something what we consider simple and fundamental done, and they're not getting it done because of the broken, fragmented healthcare system. And it's just interesting that incentives work, but you have to make it easy for people to get those things done, and that's a big part of our models. We just offload the frustration of getting healthcare done and prevention done.
Okay, so Dr. Coburn, take me through the journey. Let's take a cardiovascular patient. Let's sort of simplify it a little bit. Someone with like angina or just, heart condition, traditional model, what would happen? What would be the average cost? And then the future of health, which is what I think Medici is doing, preventative, making the service quicker, getting the cardiologist there, seeing if they need to do whatever they need to do, testing and echoes and EKGs or whatever it is. But just take me quickly through the journey so people have got an idea of saying, hang on, this is the future of health because of the costs and obviously the complexity of doing it the traditional way.
Yeah. So the traditional way is the patient often will present with chest pain, right? The patient goes to an ER, gets admitted to OBS, gets a stress EKG, watch for a day or two while they watch levels fall, make sure they're not acutely decompensating, and you got a $20,000 to $50,000 bill, right? That's the average way a patient with cardiac disease is going to present in the fee-for-service system. In our system, we want to early on screen, so we incorporate into a tool we call Health Score. I don't know if you've heard about our Health Score, but this is a near-infrared camera that looks at your face and actually gets accurate vital signs, as well as unloads some questions that are really at getting your cardiovascular risk assessment done. So we know your risk for a cardiac event in the next 10 years based on Framingham scores and things like that. And that becomes part of our onboarding into primary care, is we will talk to you about, hey, you have a 12% chance for an MI in the next 12 years. I do? I had no idea. Yeah, let's talk about what you can do now and what Medici likes to do to help you avoid that. And let's see if we can get that number down. And so that proactive, and it's not that we're using fear, but we're using reality with our patients as a motivator. And then once people have a little sense of just the knowledge of, oh, I am at risk, I am unhealthy, that introduces them into our programs. And so we will then start to say, all right, we actually have a whole program built around this. And we believe in 3 months with this intensive lifestyle management program that you will have some sticky habits that will avoid you not only not having the heart attack, but you're going to lose weight. You're going to feel 10 years younger. You're going to actually enjoy your life more, and you're going to avoid getting onto 6 to 10 medications that's your trajectory right now if you don't do something about your health. And so that kind of mature conversation and then a relationship that develops with all these different care members that form that peer group of support leads to people leaving in 3 months with 30 to 40 pound weight loss, with a huge drop in their cardiovascular risk, with new belief. And frankly, I think the belief that they can do something about their health is maybe the most important thing we're doing. People leave going, oh my goodness, I'm no longer a victim of genetics or whatever I thought was going to kill me. I am proactively doing something about this, and I feel so much better. That alone is a massive motivator of getting people through that. Oh, I can't exercise. Oh, I like exercise. Oh, I feel good. That's going to be what I think keeps people on this sticky trajectory of 20 years from now. They're not on hypertensive drugs, cholesterol drugs, having the first MIs, going on to dialysis and so forth. And we know that's true. Just with diabetes prevention alone, 90% of Americans that are pre-diabetic, this is a crazy statistic, and one of the ones that bothers me the most, 90% don't know it. 90% of people that are about to be diabetic have no clue. And it's a simple screening questionnaire that leads to a blood test that leads to information. 25% of diabetics in America don't know they have diabetes right now. That's a crazy number, because they're going on to dialysis in the next couple of years because they don't know it, and losing feet and losing vision and so forth. So we're really all about pre-screening populations that we take care of to get them aware. And then I really motivate my care team to say, it's not okay just to make people aware. Now our job, now that we're in this equation with them, is to get them into primary care that gets them into these programs that get them to develop lifestyle changes that make a massive difference. Crazy statistic, if you just get a pre-diabetic, into a diabetes prevention program, which is a lifestyle program, you delay onset of diabetes by 11 years.
Wow.
One intervention at any time, 11-year delay, massive savings, but also just think about all the burden on that patient that's avoided. So we're all about prevention by screening and getting people into an effective program and supporting them. And iterations of change is the key in this model. Is you can't just force a diet. Yet we'll often have 4, 5, 6 different versions of a diet by the end of 3 months. And this is my story. I was 30 pounds overweight. I was an old jock athlete, they call it in America, just, thought I would never die. And then I realized, dang, I can't keep up with my kids. What's going on? And I took this job at Medici and I said, this is not okay. I am the part of the problem. I have said that I'm going to wait until I get sick to address my health. And so I found after many iterations that, hey, I like smoothies. So I am now the smoothie doctor at Medici. I make smoothies every day for my whole care team. And I lost 30 pounds by just finding something I liked to eat, decreasing some of that, I would say, guilt or boredom eating, and starting to exercise. And now I just realized, man, I was the guy that didn't believe I would ever change. And it wasn't that hard. I just needed a little support to do it. And so I'm on fire for this. Everyone we hire has to believe that this is what comes first is lifestyle change. We're not rushing to medications at our program, and it works. And our average employee here loses weight and feels better and integrates into all of our programs as well.
Well, sounds amazing. And I mean, you've been in medicine, I think 30 years, and now you come to Medici, lose weight and prevent disease, and become sort of a witness to how impressive these programs are. So well done to you. Just give us the track of the other person. What would the cost be? I mean, you said like a 20,000 to 50,000 bill with the traditional model. How do the costings work for the person who's going the Medici way, or what I call the future of health? Because it's got to change somehow, because healthcare is becoming sort of unaffordable for many and becoming so expensive.
Yeah. So this model is, what we've done at Medici is we haven't invented anything other than cobbling together the right pieces of proven value-based models. So, I won't say it any other way. The truth is we believe in it, and we won't change the model. We won't decay the model in order to get paid a different way or better. And so what really happens in our model is we believe the savings for each additional dollar in advanced primary care that's patient-centric, that coordinates care, that does complexity, saves $2 to $5. So there's an actual ROI on increased investment in primary care. And the best study in America is the state of Oregon, which is a state that actually is quite progressive historically about healthcare. They actually said, you know what, we're not doing primary care as well as we should. And they're very primary care centric as a state. So they invested new dollars in a patient-centered primary care system for their Medicaid population. In America, Medicaid is a captured population. So they know what dollars are being spent on this population. And they know when they put new dollars into it, is there an ROI on it? And a lot of people don't believe these statistics, but the state of Oregon says for every new dollar put into a patient-centered primary care that had this advanced primary care model, there were $15 in downstream savings for that population. Now that's crazy. I don't know if it's 15, but I do know it's guaranteed for each additional dollar you put in advanced primary care that you're saving $2 to $5 based on everything that's been studied in the States. And when you start to really take on complexity in that model, meaning you're doing internal consultations, that's probably where you do start to see more like that $5 to $10 to $15 in savings. And that's what we're doing. Our model is all about finding the sickest people for these companies we take care of. We say, you really don't want us unless you let us help your sickest people. Because in America, 5% of employees spend 50% or more of healthcare dollars for a company. And a lot of people don't understand it. In America, we have a large contribution of healthcare dollars is coming from companies. We kind of invented private insurance, and it's become this kind of pain in our side that we're stuck to this model that's really what broke a healthcare system in America. But what these companies are figuring out is that the money that they're putting into specialty care is just a massive waste. And so they're really starting to finally be part of the solution, so that the people that invented private insurance are actually now the ones that are driving. We need a value-based model. We need something that coordinates care, that cares about prevention in the first place.
Oh, sounds amazing. So what you're saying is that 20,000, it's going to be a very different number that people are going to have to put in if they were spending 20 to 50,000 just for that one event. Never mind if you look at the whole 12 months of what they would be spending. Sure.
So our model tends to be a model that's as much as you can get. And so we tell you have unlimited access to our primary care doctors, our specialists, our nutritionists, unlimited, so that we tell the companies, do not make people to pay for advanced primary care, because those dollars going to us, those patients going to us, are going to lead to avoidance of all these other things. So our model is remarkably cheap. A lot of people really have a hard time believing that we can do as much as we say. And why that is because we really do the things that have a proven ROI in avoiding downstream costs. So we have, for instance, we have our own ER doctors on call that are really there to help you not have to go to an ER, right? Because in America, if you step into an ER, there's immediately a $2,000 to $3,000 bill. You can't avoid it. That's the real cost. That's the real dollars being exchanged. As opposed to an urgent care is $150 to $200 for an overlap of probably 90% of the care that can be provided. So just helping somebody steer them to the right in-person care with an ER doctor telling them, hey, listen, I'm an ER doctor. You do not need to go to an ER for this. You can go to urgent care. Let me call the urgent care, and we do that, and get you kind of prepped to go to the right place. And then if the answer is no, you're having a stroke and the patient was about to stay at home because they thought they were just having a bad headache, having an ER doctor get you to the hospital so you can get to the stroke team and get the clot busters is critically important as well. So that triage by the person that's best equipped to triage you at 2 a.m. is really, really valuable as well.
Does this all happen online, Dr. Coburn?
So we are able to do, we have a 100% virtual version. We say we're virtual first, not 100% virtual, because we know that care needs to happen in person, right? We know that I'm not going to virtually sew your laceration. I'm not going to virtually examine your belly for an appendicitis. But we do know that 80+% of healthcare in America can be done virtually, and the National Institute of Health, it says it should be done virtually just because of access and cost alone. So we do triage you to appropriate care, and usually that means care within our own system.
Brilliant. Tell us about the future of wearables. I've been working with corporates now for 3 years, running Made to Thrive, doing executive programs, looking at wearables. I'm wearing the Whoop now. I've worn the Aura for like 4 years of, extensive functional medicine for the last 17 years that I've been doing, in practice for 24 years, Dr. Coburn. And just looking at the patterns, doing all the labs, genetic testing, food intolerance testing, omega-3 testing, amino acid testing, heavy metal testing, GI map testing, the whole gambit, depending on the program that we offer. What is happening with sort of the executive programs that you're offering in terms of looking at things like sleep and, your REM sleep, deep sleep, HRV, and these sort of very important data points that can prevent disease and be sort of warning lights or warning bells with regards to someone's sickness and ill health?
Yeah, so a big part of our, not just our executives, but all patients are screened for their sleep patterns as well as, and then we will do, what's nice in our models, we actually negotiate reference-based pricing. I'm not sure if you're familiar with that terminology, but in the States, there's the price insurance will pay, and there's a price that I can just go negotiate a cash price. And there's often a 20x difference. That's kind of a crazy 20. Yeah, so no hyperbole, 20x. And so we will steer people to the reference-based pricing for sleep studies and things like that. But we do that for all care. So we do that for Holters. We do that for EKGs. We do that for outpatient testing, outpatient imaging. All things are steered. And that's part of our model as well, is you have a care team that navigates you to quality but affordable care. And that's a massive piece of the cost and the waste in American healthcare, is what insurance will pay for. And people go, why on earth would insurance pay 20x what a cash price would be? If I told you how insurance got paid, you would suddenly understand that. So many insurance companies are paid a percentage of the bill. So if I get paid a percentage of the bill, do I want a large bill or do I want a small bill? And so this is just a huge part of the brokenness of the American healthcare system, is that we have this just perverse payment model where nobody is incentivized to save money. They're all incentivized to actually have higher bills. So we do a lot of work to do that. But just to get to your question on wearables and kind of performance medicine and I would say precision medicine, or people are now calling it accurate medicine based on that patient's individual risks, we do a lot. So we have an oncology program where we do home testing. We do a deep dive into the chemicals in their home, and we do a deep dive into their lifestyle related thinking. And lifestyle alone, 40% of cancers are avoidable by lifestyle changes in America. That's, when we have such an unhealthy population, that's not a surprising statistic, but just avoiding alcohol, tobacco, better diet, more exercise alone is a massive lever for reducing cancers. And then going back into homes and doing some testing for heavy metals and some testing for radon in the homes and things like that are part of our oncology preventative program. So we have a program that's really the first American program that's focused on preventing you from going on to get cancer and early detection. So we do a yearly test looking for the 50 genetic markers for cancer that find cancer in stage 1 or 2, as opposed to 3 and 4, so that you have a much higher chance of survival. And then we just maximize all other preventative screening that does need to happen. Because as I mentioned, Americans are terrible at prevention. 5% of Americans are up to date on their grade A and B preventative measures, many of which are cancer related. So we're just really behind. So we maximize that. And then in terms of wearables, we actually send things to your home. So we do glucose monitoring at home that incorporates into our EMR. So my doctors are able to see where your numbers are between visits. We also have our health score tool, which is a remote patient monitoring tool for chronic disease management. It has accurate blood pressure, accurate pulse, has beat-to-beat variability, which is a more and more important measure of stress, not just stress, mental stress, but physiologic stress. And so we know, in my world as an infectious disease doctor, I can pick up on sepsis in the NICU faster with beat-to-beat variability than any other metric. In fact, maybe a day earlier than clinical acumen would pick up a sepsis patient. So there are now monitors that spit out beat-to-beat variability in American NICUs that tell you this patient is a sepsis risk. You might want to go ahead and send a blood culture and start antibiotics and see what's going on with this baby. So we are building more and more things into our health score tool so that we have the ability to track more and more things. But what's really cool is this near infrared camera is able to actually derive things that are like metabolic related things. So we think we have correlates for hemoglobin A1C, for lipid panels, for glucose. It's crazy. And because all these parameters affect blood vessels, and what the tool really is doing is looking at your capillaries and seeing the stretch and the rigidity of it and so forth, we are able to now start to get some predictors for who's going to need a hemoglobin A1C formally. And so we do use the tool now to help educate a patient. Yeah, it looks like you're high risk for cholesterol or hemoglobin A1C being elevated. Let's go ahead and get your blood test done. And then we'll do whatever we have to do to get those preventative screens done, including sending tools to your house. And so we send a paper blood test to your home where you can poke your own fingers. People are too lazy to go get their labs, frankly, is what we're seeing. Less than half of screening labs that are ordered are being completed in America. So we make it really easy, and we value those labs because we know it leads to that engagement piece. So we send stuff to your home if we have to. We do that in our executive patients. We'll do that with our rank and file patients as well.
Sure. It sounds like you advanced way ahead with regards to the traditional model. And are there many companies like Medici in the US or internationally that you know of that are really got this significant primary care model, as well as like empowering the individual with regards to any data points? Because I mean, yeah, you've got an incredible partnership, Dr. Coburn, of the individual being encouraged to prick their finger, do the labs, put the wearables on, check BP, check these very important vital signs. giving information to the primary care physician, as well as having these programs in place. It seems like an incredible partnership. Is this happening more over in the world and in the States?
I think that in the States, what we're seeing is there are like-minded individual practices. We're not seeing a large, what we call corporate medicine entity that's really put together all the pieces and has the mindset about both prevention and management of complexity that we have in our space. Those people are coming because everyone knows the answers are not to continue doing what we're doing. We're early to the game. We regularly will speak to industry experts that say, that's it, you figured it out. These are the pieces that need to be put together. So I think individual docs are doing it. A lot of people are calling themselves precision medicine specialists in America. And we're actually open to those folks joining us. What's nice is we give them all the surrounding pieces, that this access to specialists, technologies that we incorporate. We're incorporating all the time new AI technology. We're not afraid of, in the fee-for-service world, doctors and health systems are afraid of AI. We think, man, that just makes us better. In our model, we have a dermatologic tool that helps identify who needs a biopsy 20 times better than a primary care doctor.
Sure.
So like primary care doctors are sending 40 patients to dermatologists for a biopsy for every positive, 40 to 1. With this tool, we get that ratio down to 2 to 1. So think about all the wasted time and resources that are happening, and when you're not utilizing things that are just better than you at doing it. And so we're not against those technologies. We're all for them when they really lead to better outcomes for our patients.
Sounds amazing, incredible work. So, what are the big challenges at Medici or the future of health that you're facing that it might not sort of exponentially grow, or, what are your big sort of problem or hurdle areas?
Yeah, I think that the big ones are really, there's a lot of people making a lot of money in a broken system. And so there's a lot of folks that really are engaged in keeping things going the same way. But what's nice is the payers, the people that know that they're wasting money, are starting to realize this is, every year in America, the average company is spending 5 to 10% more on healthcare. And every year they have worse outcomes. And so they're like, what on earth are we doing? So I think there's a lot of momentum among the old broken healthcare system to keep things going, but they're scared to death. The reality is, we hear from hospital systems that they know they're going to be shutting down hospitals because, frankly, we overbuilt hospitals and underbuilt primary care. So change is coming. Our biggest issue, honestly, is people that are paying for healthcare need to really truly believe that a value-based model is what they need. And so there is sometimes just that momentum. The decision makers often are people that are anti-change, because when they make a decision, and it's usually HR, frankly, in our space, when you make a decision that doesn't go well, you get fired. When you make a decision that's just kind of always been bad, you don't get fired. And so we need people that are ready for a change and a paradigm shift to a system that is accountable for the dollars they're spending, and really is aligned with what, we're proud of what we pay our doctors to do. We are, there aren't many healthcare providers in America that would want the payer to see how that they are incentivized. In fact, they would be embarrassed by it, right? We are proud to show our incentive model to the people that are paying for our healthcare teams. Yeah, they want to pay for compassionate doctors. Yeah, they want to pay for better prevention. Yeah, they want to pay for complexity management. These are like no-brainers. So there's great alignment there. But the shift is, you have to be willing to shift your model from a traditional insurance model where you're paying for fee-for-service to a model that cares about prevention and complexity management.
And I know that you mainly B2B. Is there a look to do B2C, or what is the reason going B2B first before B2C?
Yeah, we do both, actually. So we have a VIP offering, a kind of virtual concierge and an on-site EE program, executive exam program. It's really more of a B2C model. And then our oncology offering is more of a B2C offering as well. And then we really wanted we thought the scalability of the model and getting the experts around my primary care was the issue. We needed enough of a supporting staff to start to allow more of a B2C for the individuals to opt in. So what we're starting to just do right now is let smaller companies that don't have 500 employees come in to get access to our care plan. So that's probably the last 3-4 months that we've been doing that. And frankly, we find that a much easier population, because that tends to be a small company that really wants the best things for their people, and they're much more agile. But we're also seeing 50 to 100,000 employee companies that are looking very hard at us. And they tend to come to us through the form of a pilot program. We'll take care of 20% of their population. We're fine with that. But yeah, it's happening. And there's a massive shift right now in mindset that everybody has to find a value-based model. We're hearing it over and over and over in the States.
Brilliant. Okay, you're a pediatrician in terms of infectious diseases as well as emergency medicine. What's happening to the health of our children in America and abroad?
You know, it's sad. During my career, I started my training in the 90s. And I remember just seeing in the late 90s a really rapid transition to very poor health among kids. Diseases that didn't happen in kids were happening. And now those diseases are not rare, they're commonplace. So we have many states in America where half the children are obese or near obese. We have many states that have massive problems with fatty liver disease in children. We have diseases we just didn't see, like bile stones and kidney stones in children from unhealthy living patterns. We have a very sedentary pediatric population in general. So there are all kinds of reasons for that. Social determinants, I think cultural, I think our health system doesn't prioritize health is one of the main ones. And I've seen this get worse and worse and worse. And so a big part of my passion is we can't just start talking about lifestyle issues when people are 50 in America. And that's what happens. The reality is we go, oh, dang, if you had just taken care of yourself, you wouldn't be having this heart attack at 45 or 50. And so we need to push lifestyle back into the conversation in pediatrics. Pediatrics was theoretically the most preventative specialty in medicine, right? And if you really think about what a pediatrician does, they do way more prevention visits than any other specialist does. But what's happened is we started to not be willing to have those difficult conversations. And I would say not have the time to have those difficult conversations. So pediatricians, my peers that are rank and file day-to-day pediatricians, are trying to see 3 to 5 patients an hour. You can't get into those difficult conversations about, hey, your son's BMI is really an unhealthy range, and we need to kind of get some changes in his lifestyle going. That just completely throws a wrench into your day to have that and try and see 3 to 5 patients an hour. And what I'm seeing is doctors are leaving primary care as burnout as any specialty in America, because the reason they went into primary care, they're not allowed to do it. They're not allowed to do preventative care. What's nice is it's really easy now for me to hire people because I tell them, and I have doctors literally crying when I'm interviewing them saying that exists, that I can still do what I went into medicine to do. And I said, yeah, not only can you do it, but I'm going to incentivize you to do it well. I literally won't let you see more than 1.5 patients per hour in my model because you can't do it well, what I'm going to ask you to do if you don't do that. So pediatrics is going to have to step back into these conversations. I have 2 daughters that are in healthcare now. One's a medical student, one's a pediatric resident. And the pediatric resident's at the #1 rated children's hospital in America. And I said, do you have a lifestyle program there? He said, what's lifestyle? And I'm like, oh my God, what is happening? Lifestyle is all the things these kids are doing that are going to kill them when they're 50 to 60 years old. You need to integrate this into your program. So I'm encouraging her in her advocacy track to actually integrate lifestyle medicine into a pediatrics training program. I think every American training program should have you finish with a lifestyle credential program. So that's a huge focus in pediatrics and really adolescent medicine and college students. College students are the least healthy human beings in America. Like, they get away with it, right? They get away with it, but they're binge drinking. They're trying things they shouldn't be trying. They're sleeping none. They're eating pizza. They're not exercising anymore. They leave college with just horrible lifestyle related patterns. And so we need to get into our colleges and say, listen, if you really care about your people, don't just give them a an STD clinic, which is what they have. Give them somebody that's having these conversations with them that motivates them to actually learn some healthy living patterns while they're in college. And we're excited. We're actually looking a lot at that space right now of how Medici can become a force for good in college campus health, and really change the way colleges think about the health of their people.
Amazing stuff as you're talking. I've just got so many goosebumps all over me, really trying to just transform lives, prevent sickness, prevent disease, take the financial burden off people. It's absolutely incredible. Last question for Dr. Coby. Being in practice for so long, people not sustaining their transformation, putting things in place, sometimes getting a wearable, seeing my nurse practitioner or seeing my health coach or one of my consultants is great. But then 6 months later, once they're not in that state of dis-ease and they're not struggling with that disorder, they seem to drop a lot of the things that have really helped them, hectic lifestyle or just busy or any trauma that happens in their life. What have been the very key, very, very important parts of your program to sustain people's transformation?
Yeah, so when people come into our program and they get put into a lifestyle program, we kind of go with the behavior change model that 3 months develops sticky habits, but we don't trust that. So what happens is when you leave behavioral or lifestyle program, our lifestyle medicine doctor will have an action plan that you leave and you go back into primary care with. And we have really frequent check-ins with the health coach as people go back into, hey, you're on a good trajectory, but let's keep that trajectory. And so reinforcing things. In fact, you may be new iterations like, hey, you know what? I think I could even do a little bit more. So we may have you stay on with the dietitian. We may have you stay on. Honestly, many patients will stay on with the behavioral health team because there's still, some thinking things around, what's going to lead to those stickier patterns. So then we have a cadence of follow-ups that happen every 3 months with our patients. So we do what we consider a very holistic measure of success for healthcare. We do a quality of life measure. And we believe what's more important than just a single question of like, what is your health-related quality of life? That's a real grounding metric for us, because as we start to see that quality of life metric fall, it introduces us back into some discussions with our patients. And we found for whole companies that as a quality of life measure starts to tank, it can lead to a massive intervention. Like we had a company that was having some layoffs and just really bad morale. And we were the ones that detected it on our side, on the healthcare side. And we went back to the company and said, hey, you've got some real issues going on with your people. Let us help you. And we had a massive behavioral health intervention, made it really easy for people to get into our programs that quickly remedied that quality of life. And we do that for lifestyle. We do that for behavioral health. We do that for musculoskeletal. So we're trying to stay abreast with where people are and not have to wait until they're kind of the wheels fall off again to know when they're in trouble.
Constant re-auditing, re-measuring, making sure that you're touching base and letting people know that you care. And this word compassion's come up many times. So well done to you, Dr. Coby. I want to just declare favor and blessing over you, to just rise up in your calling with much courage, and you're changing sort of the face of medicine and health and really moving to a healthcare model. So thank you so much for your time. I'm super excited about Medici. We don't have much here in Africa to compare to that, but we do have a very good organization, a medical insurance company called Discovery that you might know of, but not a company like yours that is taking on corporates to that degree and giving the whole package that you are.
Yeah, we know Discovery well. They're actually, to us, some of the leaders and really motivating patients to change, and we've integrated many of those practices. So yeah, well, hopefully Medici will be there in South Africa soon then and helping you out.
Brilliant. Well, thank you so much. Lovely meeting you. And we'll let you know where this is going to air and put some links to Medici. I know that you've got a very limited offering to the actual customer out there, B2C, but as you said, it could be growing. I think about 38% of our listeners are in the US. So are you mainly based in Austin, in Texas, or is it sort of spread out to the whole of the US?
We're in 20 states now, and we'll go anywhere. We tend to have a focus in the southeastern states, but Texas is our big, I'd say more than half of our lives are in Texas, but we have one customer alone that's in 16 states, and we license our providers in all the states that their patients are in.
Sure. All right, Dr. Coby, have a brilliant day. Thank you for your time. Lovely meeting you.
Thank you, Steve. Take care. Bye.
Cheers, Dr. Coby.